So after learning all about what OCD is and how it presents itself, you might be curious to know how we treat OCD. And the good news is that OCD is treatable. As I mentioned, I used to work in a treatment site that was, devoted to people who struggled with OCD. And it is the case that some people might face sort of a lifelong battle with OCD, but many people do respond to treatment and get to a point where they experience the thoughts as a lot less, either experience the thoughts, the obsessions a lot less, or experience them as much less distressing and feel less driven as a result to perform compulsions. So there are two main treatment methods that are supported by scientific research, as my head is blocking the word supported, but these are psychotropic medication and cognitive behavior therapy. Typically, the best sort of line of treatment is the combination of these, as medication might make the person experience lower anxiety, which makes them more responsive to treatment, just because they're more grounded. And if they are then more grounded and able to learn these treatment methods and use these tools and techniques, then they may eventually be able to go off medication if they so choose. So as for medication, what we're looking at typically in OCD is using SSRIs, and the scientific full form of SSRIs is selective serotonin reuptake inhibitors. And these are the most common antidepressant and anti-anxiety medication available. And not to get too into details, but what these do is they increase the amount of serotonin available in the brain. And it's thought that this is lower levels of serotonin in the brain tend to be problematic in terms of causing sort of depression and anxiety and OCD. And there's been research into which SSRIs are effective for OCD. So all of these different SSRIs are considered applicable for use in people with OCD. Clomipramine has actually been like the most studied and is maybe considered a frontline for OCD, but any of these might be, and that's escitalopram there, any of these might be considered appropriate for use depending on the specific profile of the client. It is possible that different combinations or different types of medication might need to be tried before the right one is found, but any of these are considered effective for OCD. And as a clinical psychology student, I know some things about psychopharmacology, but I'm much more well-versed in therapy. And one of the types of therapy that I'm familiar with is cognitive behavior therapy for OCD. And what this looks like is exposure and response prevention. So it can be shortened to ERP. So the exposure half of this is a treatment method that's used for many anxiety disorders, which can sort of be summed up as facing your fears in a very, sort of simplified way. But that really is sort of the crux of it. And response prevention is the element that's added that is specific to OCD and other related disorders, which can include things like hoarding and skin picking and those things with the compulsive element. But we're here to talk specifically about sort of the more traditional forms of OCD. So let's talk a bit about exposure therapy. So, and this is sort of exposure therapy, like we're going to add the response prevention element a little bit later in this presentation. So what exposure therapy involves, as the name might suggest, is exposing the client to the feared situation or object. They are then asked to endure the anxiety that's associated with that situation or object. And the idea is that with repetition, the anxiety response and in the case of those with OCD, the drive to perform their compulsion decreases. So why does exposure therapy work? So avoidance is a very common behavior in OCD and any anxiety disorder, really. And what we see is the anxiety and avoidance cycle, which is, part of what helps OCD persist. So, for example, we'll see somebody starts with anxiety, and what the natural response is typically is to avoid. If you have this awful feeling of threat, and that your body is telling you you're sure that harm is coming to you, the easiest thing to do is, well, if you say, for example, if you're very anxious about going to a party, as soon as you decide to not go to that party, that feeling will go away. And that leads us to the short-term relief from anxiety. But the problem is, as appealing and understanding as that might be, first of all, you're reinforcing to your brain that, wow, maybe that was actually a threatening situation. And secondly, you're not exposing yourself to the possibility that maybe it wasn't actually that dangerous of a situation. Maybe, for example, if this person had gone to the party and endured the anxiety, maybe after 3 to 5 minutes there, they would have realized, oh, well, people are actually, welcoming me and being friendly, and the anxiety would have subsided. But since they decided not to go to the party, they ended up not having those lessons and reinforcing that anxiety. So it brings us back to the anxiety, which they will then now be more likely to avoid next time. So this is a very common cycle that we see in all anxiety disorders virtually across the board. And it's also relevant to OCD. And what we can think of in OCD is that these compulsions are actually a manner of avoidance, because as we mentioned in the first presentation, compulsions intend to decrease the distress that an individual is experiencing. And this is the idea of what exposure therapy should look like over time. So our first little dotted arrow here is that we have this anxiety, which makes us want to escape. Again, anxiety is super uncomfortable, and it's totally understandable that anyone would want to just get away from it as fast as possible. And what people tend to believe is that the anxiety will continue to increase and go on forever, and that's an overwhelming thought. But what we see is that actually when a person does face that situation, their anxiety will peak, and that won't be fun, but it will go down. Physiologically, our bodies, anxiety is a very energy consuming process, and physiologically we just cannot maintain anxiety for that long. So we'll see that the more a person does these exposures, often their anxiety will peak faster and also reduce more quickly. So for basic exposure therapy, what we do is we gradually expose clients to the feared situation or object, and the gradually is important. So if somebody is afraid of heights and they get anxious even taking an elevator in their office building, we're not going to take them to the glass floor in the CN Tower and immediately, because that's going to be too much, and it's going to make them never want to come to therapy again, understandably. So maybe we could even start with them climbing a ladder, and then once they're comfortable with climbing a ladder and they've done that enough times, then maybe we can get them to take an elevator to the 3rd floor in their office building. And the idea is that they're exposed, they endure the anxiety, and with repetition, their anxiety will decrease. So I'm going to give a example just of basic exposure therapy for a specific phobia. And specific phobias are actually one of the most responsive to treatment psychological disorders. So I'm going to talk about arachnophobia, which I hope no one watching has it, because I'm going to be showing some spiders. So if that's something that's uncomfortable for you, maybe tune out for a few minutes. But this is a pretty simple and straightforward example of how we might progress through treatment. So if somebody presents to me with a spider phobia, well, first of all, we'll do an exposure that involves them looking at pictures of spiders. And I'm going to walk them through it. So I'm going to ask them to tell me every minute or every other minute where their anxiety is at on a scale of either 1 to 10 or 1 to 100. And I'm going to sit with them, look at the spiders with them, and talk them through it. And what we're going to see is their anxiety is going to peak, and then it is going to go down. And by having the client rate their anxiety, and stay present with their anxiety, they're going to learn that, they're teaching their brain, which is overestimating how threatening these creatures are. They're teaching their brain that this isn't actually that bad. It's not fun, but it's not as bad and catastrophic as their brain is telling them. So say we look at pictures of spiders together in session, and they go home for a week and look at pictures of spiders on their own every day. Well, when they come back, maybe in session, we're gonna go to YouTube and watch a video of spiders. And that might be a little bit higher on their list of anxiety provoking things because there's motion involved. Maybe there might be more close-ups. I should mention too that all of these different steps that we're taking would be decided, collaboratively with the client. So I wouldn't be calling the shots here. We would be working together to figure out what would be more and less anxiety provoking. And then once they've accustomed to these sort of visual portrayals of spiders, maybe we might go into a room that has a spider all the way in the corner. And that could be, very uncomfortable. Someone with a spider phobia, maybe their response has always been to, run out of the room and get someone else to take care of it. So we'll sit in the room with the spider for a while, and they'll learn that nothing happens. And then maybe I might have them hold a spider in a jar or a glass, something that brings it closer to them, but they're still protected from it. And then finally, once we get there, they might actually have a spider on them. And for someone with a spider phobia, that would be an immense feat. And it's definitely something that's achievable with therapy. And the great thing is that typically we don't generally in our daily lives, unless we're, an entomologist or something, we don't tend to have spiders on us. But the fact that they have done that means that the next time they see a spider, across the room from them, it's not going to seem like such a big deal because they've already, withstood having the spider on them and nothing catastrophic happened. So what we do with exposure and response prevention is that we add this element of response prevention. So if we go back to this anxiety cycle, people with OCD experience an obsession. They have this intrusive thought. Let's say they have the intrusive thought that they are contaminated with COVID-19. Their hands are contaminated with COVID-19 because they've just come in the house. That increases their anxiety. Their compulsion in response is to wash their hands. And washing their hands will then decrease the anxiety very rapidly, usually. But again, it doesn't give them that opportunity to learn. So what we ask is that they are exposed to their feared situation or the content of their obsessions, and then not allowed to perform the associated compulsions for X amount of agreed upon time. Excuse me. Okay, so here's a contamination example. So we might have someone, touch some garbage. Maybe they'll come into the clinic, in actually in-person sessions right now, while respecting the safety guidelines, are actually great for people who have contamination related OCD, because there are guidelines in place to keep people safe from COVID-19, but it's enough to challenge them to come into the clinic and potentially be exposed to COVID-19. So maybe somebody just with a general germ phobia, I might ask them to come in and just pick up the clinic garbage can and have them sit with it in their laps for a bit, their lap, and talk them through it, get their ratings for anxiety. And then the very important part is that they're with me, and after the session is they're not going to be allowed to go home and sanitize, or depending on where we are in treatment, maybe they're not going to be allowed to sanitize for a few hours and they have to sit with that anxiety. The goal is that eventually they will not do anything to compensate for that exposure in any way. And this is an example. As I mentioned, we tend to make these hierarchies or fear ladders for people who have anxiety and are going through the exposure therapy process. And we ask them to rate all of their feared situations out of 10, for example, or 100, depending. Usually it's the therapist's preference. So what we have here is a person has rated their most anxiety provoking situation is to use the toilet at the mall. And then if we go a little bit lower, then maybe it's touching the bathroom door. Even lower, at a 7 out of 10, it's using the doors with their bare hands to open the door to the mall. We're going to ask them to touch items in a store, or even to be in the mall, or to walk around places. So this is typically we'll ask someone to start maybe around like a 4 or a 5. So it's challenging, but not so challenging that they're never going to want to come back to therapy, and not so easy that it's not going to have a benefit for them, because we do want them to have that learning. And that is my discussion about how we treat OCD. Before I answer questions,